It's really a pleasure to learn from Melanie today and on the important topic of evidence-based clinical trial design in ALS. Melanie?
Yes, good morning, everyone, and thank you to the organizers for inviting me and Sabrina for the introduction. Today I'm going to be talking about how to design, mostly thinking through phase 2-3 trials in ALS. And at Berry Consultants, we design clinical trials in a wide range of therapeutic areas, but I've been fortunate enough to get to be involved in many different ALS clinical trials. And some of the key design choices that we often really think heavily about is what's the right inclusion-exclusion criteria? You know, what is the right cutoff for time since symptom onset to include a participant in the clinical trial? What randomization ratio should we have if we're randomizing some participants to control? What length of follow-up should we require? What's the right endpoint? And Jeremy just gave a great presentation on this. And what's the right analysis of that endpoint? And then finally, given all this, how many participants do I need to enroll in my clinical trial to have power for clinically meaningful treatment effects? And the key question that I'm going to talk about today is how we go about making these choices using evidence from historical clinical trials. So learning from past clinical trial data. How we go about this is something called clinical trial simulation. Within clinical trial simulation, our goal is really to simulate virtual patient level data. So if we're thinking about designing a clinical trial where we're going to enroll 200 participants, we want to actually simulate what the data might look like for each individual participant. And then once we do that, we can run it through our proposed design, our proposed analysis method. We can visualize what the results of that proposed analysis method might look like with this simulated data. And we can do this thousands of times to understand what's the proportion of trials that go on to be successful under different assumptions, how long on average do the trials tend to run, different operating characteristics of interest. And we really do this similar to, you know, your airplane pilot would not have flown his first flight without simulating flight first. We think the same thing about clinical trials. We shouldn't be running clinical trials without first simulating them, really understanding them, and understanding the operating characteristics of them. How well we do in this really is guided by how well we can do that realistic patient level simulation. And to be able, we are fortunate within ALS to have the PROACT database, to have this wealth of information on patient level data from previous historical clinical trials. And I'm pretty sure most of you are familiar with the PROACT database. This was a snapshot from the website, and I think it's old. It could have more clinical trials now, but when I took the snapshot, it mentions placebo and treatment patient level data from 29 phase 2-3 clinical trials. So a wealth of data. This is just a plot here of some of those participants and their trajectories over the course of clinical trials on the ALS-FRSR, which tends to be the primary endpoint within a phase 2-3 clinical trial. So you can see a large number of participants, over 2,500 participants here, and a wide range of follow-up and a wide range of trajectories. So how we use this database is we take that large database of clinical trial data and we first might screen it. We screen it for major inclusion-exclusion criteria that we're proposing in our clinical trial. So we might be proposing a clinical trial with only individuals within 2 years of onset, with a vital capacity greater than 50%. And so we would take that large database and bring it down to those who would meet our broad inclusion-exclusion criteria. And then we're interested in some summaries of this information in terms of the key clinical endpoints of interest. And for demonstration purposes, I'm going to use the ALS-FRSR. So we might be interested in what's the average value at screening for the participants. What is the mean rate of progression per month of those participants on ALS-FRSR? And this is important because if we have a faster rate of progression, we might have larger power to detect a clinically meaningful slowing in disease progression. However, the other part that's very important is the variance of that progression. The larger the variance, the lower the power. So we have to pay particular carefully attention to the rate, both the rate of progression of participants as well as the variability. So what we actually do to simulate a clinical trial is we will, instead of just using those summary statistics, we will actually randomly sample participants from this database and use their actual observed data to simulate very realistic data that would be similar to this participant. So we might be simulating a clinical trial, and the first patient that we want to simulate, we'll do it based off of this trajectory here with the black circles that we have for this individual. We also can record information on their baseline characteristics. So this individual was 1.5 years from onset at the start of the trial. They had a value of ALS-FRSR a little bit above 40. Their pre-baseline slope, or what some people will call delta FRS, is 0.33. And these are interesting prognostics to help us try to predict future rates of progression and interesting baseline covariates that we might put in our analysis model. Now, we can't use this actual observed data because it may not fall on the exact visit schedule that we're planning for our clinical trial. So we can fit a linear curve to their data, and actually we'll get to this, but these linear curves fit quite well to the participant level data, at least through 6 to 9 months, as you can see reflected here. And this individual progresses at a rate of 1.83 points per month on the ALS-FRSR. And once we have this line, we can simulate data around their line. And so this is what a single observation or single participant's data might look like in a simulated trial if they were, say, on placebo. We also want to be able to simulate data from a treatment and a treatment that potentially works. So to do that, we could take this same line and apply, say, a 30% slowing to it if we think the treatment has a 30% slowing. And then we can simulate around that line. So the green dots here are what the simulated data might look like for a participant who was treated with, and the treatment had a 30% slowing. So as I said, we can use this method to create very realistic simulated trials, and we can simulate thousands of trials to really understand operating characteristics such as power of the proposed design under different assumptions. So just some examples of this, the first question right away is, what's the right sample size and the length of follow-up for my trial? This plot here shows power, or in the case of the green line, type 1 error, which we want to always make sure we keep control of. But it shows power in the purple line of a common 30% slowing, similar to that green line I showed before, under different sample sizes, going from 150 up to 300, assuming, say, a randomization ratio of 2 to 1, with some restrictions on the inclusion-exclusion criteria. And the solid line is the power for a 24-week trial versus the dotted line, which is the power for a 48-week trial. And this is just an example of one of the questions we can try to answer through simulation. So what we can glean from this is that about 240 participants are needed for a standalone trial under randomization of 2 to 1, if we're talking about a 24-week trial, to have 80% power for this common 30% slowing. If instead we go to a 48-week trial under this common 30% slowing, we can increase power by about 5 to 8%. This allows us to reduce our sample size by about 30 participants. So now you can see we have about 80% power for the 48-week follow-up using 210 participants. So this allows us to make that benefit risk trade-off and really quantify the benefits of going to 48 weeks versus staying at a 24-week trial. Now, again, I keep saying this is under a common slowing in disease progression of 30%. We want to stress test this assumption. So what if the treatment takes a little longer to kick in? What if it's a delayed treatment effect? And that's what the pink lines are meant to show here. And so in this case, as you might expect, going longer has a much bigger benefit. So going to 48 weeks has increase in power of almost greater than 15% in some situations. So you'll really want to take into consideration both the statistical simulations as well as knowledge with your treatment when you're designing a clinical trial, mechanism of action, how long you think it might take before the treatment effect starts to kick in. The other thing you'll want to take into consideration, we don't necessarily have baked in here, is we have sort of a consistent dropout rate built in. But going from 24 to 48 weeks, you might also experience a higher dropout in a 48-week study. And so you would want to stress test these simulations of what if we had an increased rate of dropout with a 48-week study, and how would that impact our power? Another example of how we could use these simulations is to better understand our inclusion and exclusion criteria. As I said at the beginning, every clinical trial, people want to go after the fastest progressors, but that can also tend to increase the variability. And so what we actually see is that when you go from, say, a study that includes the broader population of those within 3 years of onset, and limit that down to, say, those within 1.5 years of onset, you really only increase power by about 3-4% most. And then that comes with the trade-off of limiting the population and the generalizability of the results. So we can also provide numbers such as, when we go from a trial that looks at those within 3 years of onset to those within 1.5 years, that's going to reduce our population by about 60%. And so that's an important number to understand as well. And you can get that information from the PROACT database as well. Again, the other thing you'll want to keep in mind is these are just statistical simulations showing this common 30% slowing. What if, as Sabrina alluded to earlier, we truly think that the earlier we treat, the larger the treatment effect? And so you would want to consider, again, your mechanism of action. If you do believe that those treated earlier on might have a bigger effect, we might want to simulate that to really understand what's the benefit of, say, going to those within 2 years of onset instead of allowing those with between 2 to 3 years of onset as well. And finally, the PROACT database can do other things beyond, show us power of our study. It can help us also justify modeling assumptions of how we're going to actually analyze our data. One of those that is talked about a lot is ALS-FRSR really linear? Can I assume it's linear in my analysis? Can I do a slope analysis? Well, here's one example of looking over 24 weeks within the population that we expect to enroll. And how we assess linearity is that we'll, again, fit these linear curves to each participant. And we'll look at what's called the residuals. That's the distance between that curve and the observed data. And if there is no evidence that we are departing from linearity, that would mean that our residuals would all be centered around 0, which they are here across all of the visits, and that the variability of these residuals would all be common. So we wouldn't see like smaller variability at 0 and then a larger variability later on. And so we did this analysis, and you could do this in PROACT to justify your assumptions. And the PROACT database really provided nice evidence that there was no real evidence of departure from linearity, at least within this population over 24 weeks. And there are many more things you can do with the PROACT database to help make evidence-based clinical trial design decisions. Again, what's the right primary analysis method? What's the right randomization ratio? How could I increase my power with adjusting for different baseline covariates? Because we're using very realistic data of individuals in PROACT that actually come with records of their baseline covariates, we can try to answer this question. And then finally, you might be asking, how well does this hold up? How well do these simulations hold up in practice? Fortunately, we have evidence of how well these simulations hold up in practice when designing the HEALEY ALS platform trial. And now we've actually gotten to observe data from the first 5 regimens. And what we've seen is that our assumptions using the PROACT database, as one might expect because it was built from clinical trials, were very concordant with what we observed in the first 5 regimens of the platform trial. Similar rates of progression on ALS-FRSR, which within the population. Both the PROACT database and the observed regimens demonstrated linearity. They demonstrated we have this question in the platform where we share controls across regimens. We use the PROACT database and work by Dr. Schoenfeld looking at different rates of progression across different clinical trials. And what we saw in the actual platform is that rates of progression were very consistent across the different regimens that were being tested. And it's important to understand this assumption so that we can borrow information across the different regimens. Similarly, mortality rates were very concordant with what we expected, and dropout rates. And when we redid our power calculations now using the observed data, we still had about the same power for the sample size we were proposing. So this really speaks to, I think, how invaluable historical patient level databases are like PROACT. And I'm saying that so that, both those who are designing clinical trials right now can use it to design a more evidence-based driven clinical trial, but also those who are finishing up their clinical trials will really consider donating or putting that data into the PROACT database, knowing that it is being used to develop better clinical trials within ALS. And I'll just end with 2 references that Dr. Paganoni also showed earlier that we have for the platform trial, and hope to take some questions when we do our panel at the end.
Thank you so much. This was fantastic, very important, and really speaks to the power of collaboration within the ALS community. That's wonderful. PROACT is such an incredible resource. So thank you so much, and